joining today's webinar. I'm Dr. Prachi from Shield Healthcare. I welcome you all, especially our esteemed guest speakers, faculties, and all other participants. Today, we are bringing episode T from A to Z task. This episode is brought to you by AGOG, which is Academy of Global Obs and Gynecology. We will have a short introductory slides of AGOG and followed by
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
क्या मांग रहा है?
Prachi, ma'am. Yeah, can you go to the next slide, please?
Kindly introduce coordinators.
Yes. I'm happy to introduce today's coordinators, Dr. Amrita Tandon. Ma'am is IVF consultant and a gynec endoscopic surgeon at Dr. Sudha Tandon Fertility IVF and Maternity Center, Mumbai. And Dr. Hafizur Rahman, who is a professor of OBGYN, ACOG Governing Council member, and honorary secretary of Gangtok OBGYN Society. So I'm privileged to introduce and I'll hand over the session to our today's coordinators. So thank you very much. Over to you, sir, and over to you, ma'am.
A very good evening to everyone. Thank you, Dr. Prachi. So very esteemed our guests, faculties and delegates. So I would like to sincerely congratulate and appreciate the efforts of Komal Madam and Niranjan Savan sir for conducting this Academy of Global Obstetrics and Gynecology, which I have been almost all the different series. And today's episodes on Treat and Transform, I hope is going to be a great experience or a learning experience for all our delegates, because so many stalwarts are speaking on these sessions. So I welcome all our faculties as guest faculties as well as speakers. So Komal Madam need no introduction. That is, Madam is Medical Director at Sovan Maternity and Nursing Home and Senior Consultant as well as DNB teacher. She has also been an ex-honorary professor at Dr. R.N. Cooper Hospital and HBT Medical College. And Madam is the recent chairperson of Medical Disorder in Pregnancy Committee. And she has been actively involved in MOOCs, AMOCs, and organizing so many conferences and so many things. So you can go on telling on so many things. So next slide, please. So then we have our own Dr. Niranjan Savan sir, who is also been in the coordinating with this session. So can I have the next slide? So Niranjan Savan sir is professor and unit chief at LTMMC and LTMGH Sion Hospital. Sir is the current joint treasurer of FOXI as well as president of MOOCs, and he is member of Oncology Committee of SAFOG and joint secretary of AFG and dean of AGOG and chief content director of high grade as famous courses. Sir has so many publications and coordinator of so many programs as well as editorial board member and chief editor of several journals. So I welcome Niranjan Savan sir also. Now we have, I would like to invite Madam Komal ma'am to introduce as our chief guest and take their blessings. Komal madam, to you, please.
Thank you. Thank you so much. And thank you, Hafizur, and thank you, Amrita. They have been coordinating it so beautifully. And I welcome you all to this Trending Ask the Expert series, the episode T, which is Treat and Transform. And we know that we treat all the diseases, but when we talk about something which is complex, as in with Mullerian anomalies or with tuberculosis, it becomes really a question. We are conquering, but still in India, tuberculosis is a concern. And when we have to transplant, we talk about the uterine transplant, which has caused the revolution and the hope for all the patients without an uterus or with Mullerian anomalies. And that was the idea and the topic which I had thought about. And I think I really thought about the right people, and everybody is here. So I'm really happy and blessed. And today's guest of honor is none other than Dr. Alka Kriplani. She is something who is treating and transforming patient day in and day out. And she's an icon in herself. Padma Shri Dr. Alka Kriplani madam is an ex-professor HOD at AIIMS, and currently she's at the Paras Hospital. I think she mentors so many students. I see the update and I really feel how lucky those students are. And I really wish to be a student looking at the way she takes care and with a loving gesture, she looks at all the students. I think that encouragement is really required. And a teacher par excellence, she's a founder member of AOGD and also the vice president and the president of FOXY, where I think during her tenure, we had the Pradhan Mantri scheme also going on, and we actively worked in FOXY under her leadership. She is, I think, delivered more than 500 guest lectures, so many orations, and recipient of real great honorable awards like the CL Zaveri Award, Neera Agarwal Gold Medal, KP Tamaskar Award, and so many. I think the list is endless. So we are very honored, madam, and over to you to hear your golden words.
Wow, AGOG, lovely association. And I know this couple, initially Niranjan, and I have seen Niranjan being transformed, and he was such a happy-go-lucky boy. And now he has become so senior, and Komal, you joined after him, and now you are shining. So it's an absolute pleasure. There are few FOXY couples, and you both are going to make history in future. I know that. So lovely couple of FOXY, and Dr. Tandon and Dr. Hafizur Rahman. So very wonderful scientific program I can see. Dr. Shailesh, Dr. Paul, and the topics are so catchy. And at the end, the tuberculosis. That is a problem in India still. So I think it's one of the most wonderful scientific programs being made by you people. I can see, I say Dada, Gokul Dada. So yeah, Gokulda, it's an absolute pleasure to see you. And we used to, equate Guwahati with Gokulda. Gokulda and Guwahati were synonymous. And I also follow you, Gokulda, and I watch your flowers and everything. So,
Thank you.
Komal,
Thank you.
I must congratulate you for this lovely program and for the invitation, and wish you all the best in all future endeavors. And I know behind every successful woman, there is a man, and Niranjan is there as solid support. It is vice versa also, huh, Niranjan? She is your solid support. So with these words, I think the special speakers should be given good time to speak on these topics. Thank you.
Thank you. Thank you so much, madam. You're always inspiring and motivating. Yes, Dr. Niranjan, you can speak.
Thank you, madam, for your kind words. And of course, you are an inspiration. I do agree, madam, when you were the president of FOXY during 2015, you had kept 6 programs in AIIMS. And I was that lucky one where I attended all of your conferences. And the amount of efforts which you have taken in robotic surgery, in gynae endoscopy, and the videos which you showed, I still recollect those beautiful videos which have mesmerized all of us. So thank you, madam. You are an inspiration to us, and to bless us is a very big thing to be there today with us. Thank you so much.
Thank you, Niranjan.
Thank you. And now I take the pleasure to invite our guest of honor. He is Dr. Gokul Chandra Das, sir. And we know sir is so honored and he is a great person in the East India. And we know that sun rises in the East and we always look up to Dr. Gokul Chandra Das in the East India. And he's so important to all of us and for Foxy. He is the founder professor, head of the department of TRIMHS Nagar Lagoon, Arunachal Pradesh, and professor and head of the department at Guwahati Medical College, Guwahati. He had been the vice president of Foxy in 2014, a member of the governing council of ICOG, president of Guwahati Society and the Northeastern Societies, many orations, publications, and articles in national and international journal. And we are really honored. And I think the way, I think there is one icon like in East India, and he is Gokul Das, sir. So thank you so much, sir, for being here. And over to you to address the gathering.
Thank you. Can you hear me? Hello.
Yes, sir.
Thank you, Komal, for such a beautiful introduction. I don't know how much I deserve it, but as Alka-ji has said, Dr. Niranjan, you make a power couple in Foxy, and we want to see many more bright years in Foxy. And today's program, I think, is a wonderfully chalked out program. I just wish you all the best, because I don't know, as Alka has said, we don't know to take the time from the speakers. So wish you all the best. Komal, wish you all the best. And Niranjan and Nara, all the best to you. Thank you very much.
Thank you. Thank you so much, sir, for your blessings and wishes. And Dr. Niranjan Chavan.
Thank you. Thank you, sir, for coming. I remember, sir, working with you in Sheikh Motherhood Committee in 2009, 10, and 11. And, sir, as a vice president of Foxy, you are always encouraging, you are always helpful. The type of demeanor you have, very, very cool and kind-hearted and a respectable professor, not only well-known in Northeast, but also all over India. And I recollect one of your students, Dr. Chinmay Pataki, who came to me after completion of his MD to Mumbai and was my lecturer in 2009, 10, and 11. So really, the amount of efforts you have taken to train all those postgraduate students and to make them confident. Today, Dr. Chinmay Pataki is very well settled in Dombivli. He has 2 nursing homes, and he is a very well trained and a person who goes all the way to to do endoscopy and IVF. So thank you, sir, for those kind efforts which you have taken for all our students.
Thank you so much, Dr. Niranjan. And with that, I thank Dr. Alka Kriplani Madam and Gokul Das Sir for gracing the inauguration of this program. And I'm so happy and honored that we have our eminent speakers today, Dr. Shailesh Puntambekar, Dr. P.G. Paul, and Dr. Padma Rekha Jire. And I have all the chairpersons who have joined, Dr. Malvika Sabharwal Madam. We know that how busy she is, but I'm so happy and glad that she's here. Dr. Farendra Bharadwaj, he is one of a dynamic person from Rajasthan. Our very own dear friend, Dr. Albert Sandara. My dear friend, I think Vaishali, she has joined. Dr. Abhishek Chandavarkar, they have joined. I welcome them all and all who are going to join in the due course. I'm happy and honored and welcoming all of you for this program. Dr. Puntambekar had to, he had some flight got rescheduled and he had to board a flight, but he has recorded his talk and he sent. So may I request the coordinators to take over from now, or introduce our chairpersons, and they would be introducing Dr. Puntambekar, and then we'll have his talk.
Sir, you're on mute. Dr. Rahman, you're on
Yes,
mute.
Thank you, Komal Madam and Niranjan Saman sir, as well as our chief guest Alka Madam and guest of honor Gokul Das sir. So without wasting time, we'll start our session. That is, the first session is by none other than Dr. Shailesh Pantambekar, and I have been fortunate him to learn on this topic way back at least 5-6 years back, and it was wonderful. So without wasting time, I'd like to start on this session. I'd like to introduce our chairperson, that is Dr. Malvika Sabrawal Madam. So Madam is, can I have the next slide? So Madam is Chief Department of OBGYN and she is a laparoscopic and endoscopic surgeon at Jivan Mala and Apollo Spectra Hospital. And she's been so great personally. Actually, I have also seen her in many conferences, and she was awarded by Padma Shri by Government of India and recipient of Dr. APJ Abdul Kalam Excellency Award. And she has been awarded by Dr. Satyapal Award, also founder, chairperson of IAG Delhi, past president of Delhi Endoscopy Society, first president of Delhi Endoscopic Forum Central, and executive member of OBGYN Society of Delhi. And she conducted so many programs and invited faculty in so many national as well international conference, and organizing chairpersons in different conferences in the different parts in the Delhi and other areas. I welcome you, Madam. So our next chairperson is Dr. Farendra Bhardwaj sir. So, sir is Professor, Department of Gynec Endoscopic Surgery at Mahatma Gandhi Medical College and Hospital at Rajasthan, and he is the he's the IAG Managing Council member and Vice President of AGESR, Joint Secretary of IAG Rajasthan Chapter, and Founder Secretary of Association of Gynec Endoscopic Surgeon of Rajasthan, as well as Founder Treasurer of IAG Rajasthan Chapter. So he is also organized that Endo-Ferticon 2019. So I welcome Farendra Bhardwaj sir to chair this session. We have our next chairperson, Dr. Edward Saldanha. So sir is Senior Consultant OBGYN and Laparoscopic Surgeon at Sriji Hospital and Shatabdi Municipal Hospital at Mumbai, and President IMA Chamber Mumbai. So without wasting much time, I would like to hand over the session to our chairperson and invite Malvika Madam to introduce our speaker of this session, Dr. Shailesh Pantambekar sir. Over to you, Madam.
Well, thank you so much, Dr. Hafizur. That was a very kind introduction that you gave. I'm so happy and honored to be introducing Dr. Shailesh Pantambekar, though he is not here in person. But it's a real. I have the pleasure of introducing him. He's a director consultant laparoscopic oncosurgeon at Galaxy Care Laparoscopic Institute in Pune. Patented the technique of laparoscopic radical hysterectomy, and we all know globally it's known as the Pune technique. He conducted India's first successful laparoscopic assisted uterine transplant, and a baby girl was delivered on 18th of October 2018 at Galaxy Care Multi-Speciality Hospital. So the only Indian to be board member of AAGL and faculty and member of AAGL Oncology Committee. He's selected as the International Secretary Treasurer for AAGL, working closely with AAGL board to promote and teach laparoscopy internationally. He is operating faculty at IRCAD and various other international organizations and the conferences. He's got the largest published series of transthoracic esophagectomy, endoscopic robotic, both. He has got, recipient on many awards, Foundation and Signature Award from AAGL, and also recognized the Golden Telescope Award, which was again by the AAGL, and he got numerous awards. So having said all that, he's got a very important topic today of uterine transplant, which he did very successfully in the year 2018. But remember, we are now discussing on the current progress and the future proposals. That is what we would like to know from him and learn from him as to where we stand, because the first transplant, when it happened, it was preceded by a number of, there was a lot of work which was done earlier, wherein it started as early as 2000 in Saudi Arabia, which it failed. Subsequently, various countries kept trying. And there was a very nice, this was in Turkey in 2011, wherein they successfully did a transplant in a young girl who was she was about 30, MRKH syndrome. But unfortunately, what the uterus that she was given was from a diseased donor. So it was not successful. Subsequently, in Sweden, in 2012, a mother who was 61 gave the uterus to a 36-year-old daughter who had a baby in October 2014, which was a healthy baby born. In USA, also, they were not far behind. In 2017, Dallas gave a successful transplant. Cleveland had earlier tried in 2016, but somehow it had failed. And to the extent that a hysterectomy was done subsequently because of some unrevealed complications. So we were so proud when in Galaxy Care Hospital, Pune, Dr. Sailesh did the first uterine transplant. The date was 18th of May, 2017. I remember that so distinctly because we were having a conference and he had to come to Delhi for the conference and he could not because of this reason. And we were extremely happy when this happened because it did India great proud. And today we know that, this is something which will give a lot of, this is the only answer to anybody, any girl suffering from MRKH syndrome. This is the only answer. And also other Mullerian anomalies wherein uterus is not amenable to having a baby. So this is something that they look up to. But again, there are other criteria which came up. We all know about the other criteria, the Montreal criteria, which came in just to give guidance to the clinicians as to how we are going to further progress. Because looking at the future prospects, we have to keep it in mind that looking at the transgenders and men wanting to gestate a fetus, these are probabilities which will be our future. So we need to discuss it all and we need to know it all. And we look forward to this talk. And may I request Sailesh to please go ahead. Thank you very much, Dr. and Hafizul. We can start with Dr. Sailesh's talk now. Can we make it full screen, please? Can everybody hear? Hafizul, can everybody hear it?
Not yet, madam. I think.
No, just share.
Good morning, everybody. I'm going to share my experience on uterine transplant. So greetings from India and Galaxy Care Hospital, Pune. We at Galaxy Care have always strived hard to improve our work and tried to progress as per the medical science. So on 18th of October, our first girl child was born after a uterine transplant, and we were able to make our country proud. And this is what we felt, we did it, and we made history. This is a girl who was born out of the uterine transplant. This is India's first born after the uterine transplant, and her name is Radha. She was the 12th girl to be born after the uterine transplant. This was not achieved overnight, and we had to overcome a lot of hurdles, so some of which I am going to share. This was a team that we had to form so that we could do a transplant, which included high-risk obstetricians, plastic surgeons, vascular surgeons, gynecologists. And we learned a lot of things when we started doing these kind of transplant. What is different in uterine transplant is that it is a non-vital organ transplant. This is the only organ which is lying outside the abdomen and thorax. And instead of giving life to an ailing patient, it is creating life out of a transplanted uterus. But the wait is too long. You have to wait for 17 to 18 months to get the final result of life. And therefore, it is a very big waiting period. You don't have to give a lifelong immunosuppression, as the uterus can be taken out once the birth of the baby takes place. The question is it necessary? For the ladies who are born without the uterus, the only options were adoption and surrogacy. But now the third option, transplant, is available. This is called as a transplant is done for when the patient suffers from AUFI, which is absolute uterine factor infertility, which can be congenital or acquired. The congenital, the commonest one is the MRKH, and non-functional anatomical uterus and uterine malformations. In our country, we have 1 in 5,000 females who are born with MRKH. So we have a long list of people who are having uterine agenesis or absent uterus. There are problems with adoption, which I should not be going into the details. And there are problems with surrogacy. Majority of the advanced nations do not allow surrogacy, as a result of which the only option for them is adoption. Adoption will give you legal motherhood, surrogacy will give you genetic motherhood, but uterine transplantation will give you legal plus genetic plus gestational motherhood, a wholesome experience. So who else can benefit? The transgenders can also benefit. We got this idea when we saw the first lady who was having a child in 2014 in Sweden. And after that, the things that went to our mind was whether we can do this laparoscopically and why do we need 14 hours to take out the uterus. In preparation of the uterine transplant, we started working our anatomical thing on the human cadavers and trying to understand the anatomy of the external iliac artery and the vein, to which we were finally going to join the uterine artery and the uterine vein. Since we do a lot of gynae-oncological cases, every patient of radical hysterectomy, the uterus was subjected to a methylene blue test to find out the vascularity. And we realized that one uterine artery and ovarian vein can bring about a complete vascularization of the uterus, understanding that the secret lies in the uterovenous anastomosis. We did the first laparoscopic one, and we had a bilateral ovarian arteries and veins which we took, as well as bilateral uterine veins. And this is the length of the pedicle that we got in all these patients, about 9 to 10 centimeters, so that we could easily reach the external iliac artery and the vein. This is a small video where you see we did world's first laparoscopic retrieval of the uterus. And this was done laparoscopically, so the mother who donated the uterus didn't have to undergo open surgery. This is the dissection which you can see, and there we can see that the uterine artery has multiple branches, and these were clipped and these were ligated. You can see the uterine artery dissection, you can see the ureter underneath, and this is how every single branch of the uterine artery was clipped. You can see the multiple clips. The ureter was completely separated out and the uterus was completely dissociated from the uterine attachments. So thus you can see the ureter being dissected laterally, and these are all the branches of the uterine artery which are ligated. The internal iliac artery distal to the origin of uterine artery was ligated. You can see the entire uterine artery and a long length of the uterine artery being dissected. And this is how we also took care of the uterine vein, since we don't use the uterine vein for the anastomosis. Then a colpotomy is done, and once the colpotomy was done, a cervicovesical fascia was then completely stitched using a barb suture to prevent any kind of bleeding following revascularization. So this is the internal iliac artery. This is ligated at the last, as well as this is the branch of the internal iliac artery, which is the obturator artery. So you can see the internal iliac artery ligated distal to the origin of the uterine artery, and the anterior division of the internal iliac artery is then completely cut and taken. Similarly, the ovarian veins are also clamped. You can see the ovarian veins which are clamped as far away as possible, and they are then cut. And the entire uterus is then completely delivered. A similar thing you can see on the right side. These are the ovarian veins which are clipped and cut, and similarly the internal iliac artery which is clipped at the level of the division. Then the patient's uterus is brought on the block of ice, and the entire uterine artery and the vein are cannulated, and a custodial solution is used so that we could immediately completely see whether there is any leak. So you can see the pedicles which is used, they are completely drained out of the blood, and the uterus is now ready with its pedicle to be anastomosed in the recipient. In the recipient, the bed is already prepared, and here you can see the ovarian vein being anastomosed to the external iliac vein. This is done with 7-O-proline. First anastomosis is always the ovarian vein, and once this is done, then we do the external iliac artery with the uterine artery anastomosis. So this is how we did this anastomosis, again with a 7-O-proline, you can see. And once this anastomosis is complete, you can see the color of the uterus, which is quite pink and healthy. And then this is joined to the vagina, and that is how we complete the entire surgery. So this is the length of pedicle that we achieved while laparoscopy. The time we took was about 8 hours, and our patient had successful menses 48 days after the transplant. So these are the various areas. The innovations that we did was, instead of using the uterine vein and the internal iliac vein, we use the ovarian vein. This is how we realized that once we cannulate the uterine artery, the entire dye comes out through the ovarian vein, establishing the utero-ovarian anastomosis, and therefore we started using the uterine artery and the ovarian vein. And this was then seen in the graft which was taken out. So this is the actual graft of the specimen of the uterus which is going to be transplanted, and you can see sufficient length of the pedicle which was available for us for getting this right up to the area. So the uterus can survive with one uterine artery and one ovarian vein, and advantages of abandoning uterine vein is that it can easily lie without traction on the either side. Then what about the ureters? The ureters get devascularized. So we always put a patch of momentum, and we put a double J stent in the donor so that there is no fistula formation. The rest of the area, we did the same kind of thing. And not only that, what about post-operative monitoring? Because the uterus lies outside, we have to do invasive monitoring with colposcopic examination and biopsy, and non-invasive with the Doppler. The patient has to take a lot of precautions in terms of preventing any sepsis, and therefore there is isolation which is done. And of course, the immunosuppression with methylprednisolone, antithyroglobulin, tacrolimus, and MMF and plasmapheresis. So all these are the drugs which are done. Tacrolimus levels have to be maintained between 5 to 10 nanogram per ml. All the recipients started menstruating normally. Before the procedure, we had to do an IVF because we have to use we have to prepare the embryos because they will not have a natural conception. So this is the difference between the MRKH patients, that the ovaries are higher up, and therefore the pickup of the oocyte can be very difficult. These are our average number of oocytes that we got out of every recipient was about 9, and these oocytes then were converted into the embryos. And then you could see, these are the Doppler images of the patient. You can see a nice flow following the surgery, not only inside the uterus, but also along the vessels area. Then what are the difficulties in embryo transfer? Improper vaginoplasty and a fibrosis between the vagina and external os can lead to bad transfer, and therefore we have done trans-abdominal embryo transfer, as you can see, and also trans-cervical embryo transfer. So these are the various types of other things that we do instead of doing a trans-cervical embryo transfer. So challenges, there are a huge number of challenges. I will not enumerate all of them, but the most important challenge is to do an embryo transfer. So this was our first embryo transfer, which we did trans-vaginally, and you can see that the embryo was transferred very, very easily. Though this lady had, first time when we transferred the embryo, had an abortion, but later on delivered a normal child. These are the number of embryos that we have frozen. And of course, after completion of delivery, we have done the removal of the uterus because the person should not be on lifelong uterine lifelong immunosuppression. So this is the post-transplant uterus. You can see that there is the uterus which had already delivered a normal child, and this uterus had to be removed because the patient had 1-year-old lady, girl, and therefore it was necessary that we take out the uterus. What happens is the formation of pseudoaneurysm at times, and you have to be careful. So you can see a pseudoaneurysm over there formed between the anastomosis with the external iliac artery and the vein, and you have to be careful. So this aneurysm was then ligated and the uterus was completely removed. So this is one of the complications that we get after the transplant, is that the uterus goes higher up, and therefore we had to put the uterus back into the vagina. This was the uterus which we put back into the vagina. You can see the uterus being put back into the vagina because it had shifted higher up, and therefore these are few things that you have to learn when you want to do an embryo transfer. We brought the cervix back into the vagina so that the embryo transfer later on becomes easy. So these are various areas. What about pregnancy? During pregnancy, there is always a risk of any kind of teratogenicity, but you can see that in all our patients, nobody had a teratogenicity. We use elective cesarean section at 32 weeks because you cannot wait for a longer time. And then we have our experience right now. Total uterine transplant that we have done is about 9. And we have so many patients, about 224 patients of MRKH waiting for transplant. So in all the centers where the uterine transplant was done, the first few transplants were failure because of fungal infections. But at our place, we didn't have any failure. We didn't have any immediate rejection. And all of them were initially successful. What is the world scenario? The first one was done in Saudi Arabia. 20 live births have so far taken place. These are the various countries where the uterine transplant is being taken place. This is our place, and you can see that this is now given so much of importance that it has come in the Time magazine, that the future of the babies. So we have also published this. Not only we published the laparoscopic assisted uterine retrieval, which was the first time in the world that the uterus was retrieved from the donor laparoscopically. We also use this utero-ovarian anastomosis, and this is also our published data, where we use just the uterine artery and the ovarian vein. So we did not only did we do the first laparoscopic retrieval, we also want to be doing the vascular anastomosis, and we will be doing the vascular anastomosis also laparoscopically in future. So meet the team which created the first uterine transplant in India, and the lessons that we have learned: single vascular anastomosis is sufficient. Uterine transplant is a complete answer to absolute uterine factor infertility. And the most important thing is laparoscopic retrieval is very much possible. And this is embryo transfer can be a very tedious process, but if you really plan it well, you can transfer the embryo. The most important thing is there is no morbidity and mortality which is associated with uterine transplant. So creativity is thinking about new things. Innovations is doing new things. This is like climbing the Mount Everest, and we have achieved our peak by doing something which we have done in our career. We always wanted to do more than what we did in oncology, not from excentrations. And this was a creative surgery which we could do with laparoscopy. So this was, and therefore I consider myself a person who is lucky because I did it. I wanted to believe that science has its own beauty and we could perform this kind of surgery, thinking ahead, and did it laparoscopically. So with our knowledge of science, the days are not far when even men can experience pregnancy. So thank you very much for this opportunity. And I hope I've given you insights into how to conduct an uterine transplant in a center. Thank you so much.
Well, that was an excellent talk. Excellent talk. But I think Satish is not here to be answering any questions. But amongst ourselves, all the chairpersons can have a little thought process, because the last closing statement of men also wanting to gestate a child, or for that matter, transgenders. So such are the problems that we should actually think about in the future, especially with transgenders now becoming legalized, etc., in various countries. So we should definitely think. So anybody would like to say amongst the chairpersons or?
Yeah, Dr. Egbert here.
Yeah.
Excellent presentation as usual from Dr. Shailesh.
Mm.
Yeah, I mean, I think with any new procedure, there are always going to be a lot of ethical issues which are going to come up. And I think as time goes by, things will get clearer. But as of now, I think for those patients like MRKH or and absent uteri who want to get pregnant and who can afford it, probably a good procedure.
Yes,
and
absolutely.
With surrogacy becoming near impossible, I mean, literally banned now in India. So I think this is an option to some of our mothers who probably like to have their biological and genetic offspring.
Yes, I think it's wonderful for such MRKH syndromes. And patients have now, I mean, he already said that he's got a queue of so many numbers waiting for this kind of a transplant. I think it's wonderful for them. But the only thing is that one has to be definitely looking back always ethically and having, especially for one is worried about the men and how it is, the nature just giving way and men wanting to actually have babies, etc. Science is progressing like anything, but there should be some kind of a, some brainstorming which has to be done constantly by bodies, which should be made. And also one should share any complications, etc. amongst ourselves. I think it is wonderful, and very importantly, after the family is complete, of course, they have to do a hysterectomy because they cannot keep giving immunosuppressants, which is a big thing. It can be life-threatening. And as it is in other centers, wherein Sweden and other places where he quoted, especially I was, while I was going through, it was very interesting to note that in Cleveland, when they had a failure, they have not revealed why it failed. But of course, it's always good to share your complications because we can't all afford to make complications. That was very nice.
I think the best part about, what Dr. Shailesh is doing is that he's managing the donor, managing to get out the uterus from the donor laparoscopically. And that's going to be a big plus. I mean, if you can avoid a major surgery, open surgery, definitely it goes a long way, and probably benefiting the woman.
Yes, and they're doing it in simultaneous theaters,
Yeah.
Adjacent theaters.
Yes.
Immediately. So it's done right away. And I think he explained it extremely well.
Dr. Farendra,
very well.
Yes, your views.
Hello, Komal ma'am. Good evening. So it was, as usual, a wonderful talk, and Dr. Malvika madam has very, gone into the details of the history of how, the globe and the world is moving into this transplant, which is, of course. Now, having said that, there's something the male is, wanting to have a uterus and the gender exchange. Of course, the gender changing surgeries. There are a lot of surgeries, are going in the system where the female will want to become a male and the male want to become a female.
Yes.
And sort of a thing. But there's one question. Yeah, there's one question is like, there is an option of becoming a single mother. An unmarried girl can become a mother, but this unmarried guy cannot become a father. So there are many issues which we need to address, madam. And even government and the social thing need to accept. So fine, I think they all need a psychological treatment and the other things. Even when we see the congenital adrenal hyperplasia patient, they are genetically female, and when they develop sexual you can say ambiguity, or when they understand that they are probably a male or female, at that time we need to address such child to go preventing going into this what to say, sexual dysmorphism or something like this. So many things which we need to address at a social level. But yes, of course, at a scientific level, uterus transplant is excellent surgery. We are really going ahead, and thanks to Dr. Shailesh Putambikar sir, and best wishes to you, Komal ma'am. We all are supporting you.
Thank you so much. Thank you.
So all the best, Komal.
Yes, thank you
so much for a wonderful session.
Yes,
Thank you so much. Thank you so much.
Thank you, Albert sir. Thank you.
I think
Thank
we had a lovely session, and in the morning I got a call saying that sir had a flight, and again his assistant Madhvi, she just called me 10 minutes ago that have you checked everything and everything is all working? Yes, I said the talk is all working, don't worry. So he really wanted to be there, part of the program physically. Thank you so much. I'm really honored that Dr. Malvika Madam, Dr. Farendra, Dr. Elbert, they all have been there. And we had a lovely, insightful discussion about the uterine transplant, how we can take it forward and how helpful it is. And another doyen here who is waiting to speak, and he's also going to touch upon some certain aspects of Mullerian anomaly. Dr. PG Paul sir is here, and we know that such a great endoscopic surgeon he is, and so many students have benefited the immense knowledge which he has. So over to you, coordinators, to call upon our next chairpersons and introduce Dr. Paul.
Thank you. Yeah,
Thank
thank you,
you.
our chairpersons, Malvika Madam, Dr. Farendra, and Dr. Esbert. So we'll move
Thank
to
you.
the second session. And for this, I would like to invite my co-coordinator, Dr. Amrita Tandon, to introduce our chairpersons. And the speaker is Dr. PG Paul. So Dr. Amrita, please stay.
I'd like to thank Chauhan
Yeah, please.
and Dr. Niranjan Chauhan sir for this opportunity. Without wasting any more time, I would like to introduce the chairpersons for this for the next talk. Unfortunately, Dr. Rajul Tyagi Madam is caught up in an emergency, so she will not be able to join us. We have with us Dr. Vaishali Chauhan, who is the clinical director of Cloud9 Hospital, Pune. She's a postgraduate teacher, chairperson of the Perinatology Committee of FOXI in the past, honorary general secretary of the Pune OBGY Society, and she has many publications to her name. Welcome, madam. I would also like to invite Dr. Abhishek Chandavarkar, who is an associate professor at the D.Y. Patil Medical College, director and consultant at Apeksha Maternity and Nursing Home. He runs a mobile endoscopy unit at Jupiter, Fortis, Hiranandani, Cure, and many other hospitals all across Navi Mumbai and Thane. Ex-managing committee council of the IAGE. And I would now like to invite Dr. Vaishali Chauhan to introduce our very esteemed faculty for today, Dr. PG Paul sir.
Thank you, Dr. Amrita, for the kind introduction. And thank you, Dr. Komal, for this invitation. Thank you to Dr. Komal, Dr. Niranjan. It's indeed a privilege to be here. And Komal, we wish you all the best and all our best wishes for you for the forthcoming elections. And please also thank you that it is a very high privilege for me to chair a talk by none other than Dr. PG Paul. Sir is the biggest icon of laparoscopic surgery. He is a living legend. And we have all watched Sir operate, and we have been learning from Sir since years and years. Sir is also Chairman Paul's Hospital, Kochi, India. He is board member of ISG, elected member the Society of Reproductive Surgeons, ASRM, since 1997. He has authored 2 books and contributed many chapters. He has invited lectures and live surgery workshops, more than 270 all over India and abroad. He has trained thousands of gynecologists, and he has also got Lifetime Endoscopy Empowerment Award. Welcome, sir. We are indeed waiting to hear you speak.
Thank you, Vaishali, for the kind introduction. And I also thank Niranjan and Komal for giving me this opportunity. Can I share my screen?
Yes, sir.
Yes, sir.
Do you have my screen now?
Yes, sir. We can see, sir. Just full screen.
Okay.
Yes, sir, it is.
Yes. Thank you. I'll be speaking on obstructive Mullerian anomalies, some of the cases which I have come across during my practice. Obstructive reproductive anomalies are very important because majority of the patients have severe symptoms like severe dysmenorrhea and pain. And some of them, majority of them present as a case of primary amenorrhea. But even if some patients present with the menstrual cycle, occasional cases you may have still an obstructive or partial obstructions. First, we'll talk about a few of the vaginal anomalies I have come across. The common ones are transverse vaginal septum, and recently we find many cases of obstructive hemivagina with ipsilateral renal agenesis. We call it Ovira syndrome. This is a 28-year-old woman who had lower abdominal pain but had menstrual cycles, and you can see there is a bicornuate uterus, and this is the graphical representation where there is one half of the vagina is obstructed. You can see the uterus didelphys, and the inspection shows we are looking for the ureter. The left ureter is clearly visible, and you can see that there is no evidence of right ureter. We performed a vaginoscopy, and you can see the cervical canal with the normal vaginal side. You can see only one ostia, and we are looking for the obstructed hemivagina. This patient has intermittent obstructive features, and there was no obvious hematocolpos, but we tried to aspirate and find out where the probable site where we could aspirate some amount of mucus, and this is the obstructed hemivagina. This is a complete vaginoscopic procedure, and with the resectoscope, the standard 26 French resectoscope, we are trying to enlarge the whole obstructed hemivagina and excise any remnant of the vagina so that the future obstruction will not occur. Now you can see both cervical canal, and we have completely almost excised the obstructed vaginal septum on this side. The cervix is now visible, and this cavity also is normal, except that it is only one ostia as we expect. Now we try to identify by probing the hemiuterus, and we also performed a cystoscopy to make sure that our diagnosis of absent kidney on that side. This video is available on the video article of JMX, which we published some time back. And occasionally there can be cases where we have a obstructed hemiuterus, and how do we manage such patients? It's a 20-year-old unmarried girl with severe dysmenorrhea of 4 years, and ultrasound shows, and we plan for a hysteroscopy and laparoscopic excision of the obstructed adnex, obstructed hemiuterus. As you can see that the obstructed side, definitely there will be endometriosis, and you can see the adhesions, and we are trying to remove those adhesions before we proceed with the hemihysterectomy of the obstructed side. You can see the ovary is normal, and you can see few adhesions on the anterior side, and we need some amount of bladder dissection before we proceed for. We again confirmed our findings by a hysteroscopy, which shows only one cavity in continuity with the cervix and vagina. And you can see the transillumination on laparoscopy. So we are trying to identify the ureter. We normally don't perform a stenting, but occasionally we can perform if you have any difficulty in identifying. But nowadays we rarely perform, but traditionally we have been taught to do stenting in such cases intraoperatively. So we are trying to release the adhesions on the round ligament side. We would definitely want to keep the ovary when we perform this hemihysterectomy for the obstructed side. The ovary is normal, only the tube and the pelvic side wall you had adhesions because of this. The hemihysterectomy was comparatively straightforward without any surgical intervention on the normal left horn. It was a straightforward, and this is and then the patient made a uneventful recovery, and she is pain-free. We had few cases of cervical malformations, and this is one of the rarest of this, 1 in 80,000 to 1 lakh. And the cervical defects can be a complete cervical agenesis or cervical dysgenesis causing fragmentation, fibrous cord, and obstructions. This is the classification by Rock et al. Many of these cases, almost 70% of these cases, cervical agenesis will have a vaginal aplasia. So there is a need for reconstructing both the cervix as well as vagina in such cases. They have paralyzing obstructive symptoms because there is no cervix and there is no outlet, and there will be associated endometriosis and adenomyotic changes. You can suspect this condition, and normally you need an MRI to confirm the exact site of obstruction and confirm the diagnosis of cervical agenesis. If there is vaginal agenesis, definitely you have to create a new vagina, and people have done the cervical reconstruction with skin graft, peritoneal graft, and similar procedures. Some people do it in one sitting, and occasional reports are there where they first construct the vagina and suppress the menstruation, and then later on perform the cervical reconstruction and join with the vagina.
We are presenting a case of laparoscopic assisted neocervico-vaginal reconstruction for a 15-year-old.
This is a 15-year-old girl with cyclical abdominal pain since 2 years, and she has not attained menarche. A small built girl, only 38 kg and 18 BMI. The uterus, you can see it's a hematometra, and also there is a rudimentary horn, and there is a hematosalpinx on one side. Vagina was not there, cervix was not developed. You can see the MRI shows the rudimentary horn as well as hydrosalpinx, and we plan for a lap assisted. This is the picture when we started the laparoscopy. You can see hematometra, you can see a lot of blebs because of the inflammatory changes because of the endometriosis. And we made a fundal vertical incision to drain the hematometra and also to create the neocervix. We are doing the laparoscopically entering inside doing a hysteroscopy actually with the laparoscope. And now we will come to the vaginal part to reconstruct the neovagina. Being a small girl, we did not plan for any graft or anything. With the vestibule itself, we were trying to create a vagina. You make an inverted T-shaped incision on the vestibule, and then bluntly dissect the vaginal space till we reach the. Now laparoscopically, we dissected the bladder fold and to make a neocervix at this point. There is no cervix or isthmus, so you have to make a new one, and this is how we identified that area. We passed a Maryland forceps through the fundal uterine incision and then pierced through the neovagina. And once we pierce through the neovagina, the cervical canal is made and it is sufficiently widened, because one of the most common complication is pre-occlusion of the neocervix. So we try to enlarge sufficiently before anastomosing this neocervix to the vagina. Now a Foley's catheter was pulled in from the vagina into the uterus, and you will be suturing over this Foley's catheter for your reconstruction. You can see the Foley's catheter emerging from the neocervix and going into the neovagina. So I already mentioned we enlarged the neocervix, the artificial opening we made onto the uterus, and you can see that we are putting an Alice. And this neocervix, you can see the Foley's emerging from the neocervix, and again further it's thick uterine musculature, so we are trying to enlarge it and then taking bites and then fixing onto the neovagina we created. It is actually a vestibule reconstruction, because a young girl graft and other things will be more difficult, and we are suturing this to the neovagina. We'll show you the end results of this at the end and follow, so that you can see what actually happened, what we could achieve by this surgery. Interrupted sutures were taken. 4 or 6 sutures were taken from the neocervix to the neovagina, and you can see the Foley's emerging from the neocervix. And the reconstruction is complete. Now, the Foley's catheter, if you just keep it inflated, probably it will not last for a few days. So we physically sutured this Foley's onto the myometrium with an absorbed suture, thinking that it will remain there for at least 3-4 weeks. And after fixing this, the myometrial defect we made were closed down with interrupted sutures, and the final reconstruction of the uterus. You can see the uterus is quite adenomyotic because of the obstructive features, and you can also see that there is an obstruction and there is a hematosalpinx, and we plan for excision of the hematosalpinx rather than making a neostomy. Anyway, this patient may need a future ART or anything if at all she want to get pregnant. So you can see there is a rudimentary horn on the left side, which is not canalized, and the normal uniconvate uterus on this. We put a Foley's catheter, and we kept a small vaginal plastic mold inside the vagina, and the intravaginal plastic mold was removed on 4th postoperative, and the patient was taught to use this plastic pipette as a vaginal mold, and the Foley's catheter spontaneously expect after 21 days. Now you can see on the 4th postoperative, the transabdominal scan shows the uterus has come down. You can see the Foley's, and after 1 month, the uterine size still has come down. At 3 months, it has become normal 6 centimeter, and you can see the endometrial thickness of 6.5 millimeter after 8 months. Now this is the neovagina. She is still occasionally using the plastic. Now it is almost 3 years. She is asymptomatic and she is comparatively comfortable and carrying on her studies. This is also we have published in JMIG article, JMIG as a video article, and this is anybody can access this. The complications, we know that endometritis, PID, bladder injury, restenosis, these are the common problems. I will not go into this pathogenesis, and genetic basis, the epigenetic modifications of the homeobox genes, and they are hypothesized to cause defect in the Mullerian reproductive tract by interfering with the cell migration during the organogenesis, that is genetic basis for it is epigenetic theory. Our own Professor B.N. Chakravarti published 18 cases in 2000, and he reported 2 live births. Dr. Alka Kriplani has published 5 cases, and she also had 2 pregnancies out of this. And the recent series in 2014, they have published 8 cases and 2 live birth. This is in short, the literature search shows the number of cervical agenesis has been treated conservatively. And to conclude, obstructive Mullerian anomaly is one of the most severe problems in adolescents with severe dysmenorrhea, and majority have primary amenorrhea, but I showed you some of them may have a partial obstruction or heavy obstruction causing normal menstrual cycles with this symptoms. So an awareness of this is very important. Many times people treat these patients haphazardly without going into a correct diagnosis, and you have to think about all the possibilities and discuss with your colleagues or whatever information you have before embarking on surgery on such patients, because these type of surgeries are comparatively rare. Many of us may not come across many cases, and you need expertise to properly manage these patients. MRI is very useful in these cases. Apart from ultrasonography, you can make a provisional diagnosis, but MRI definitely helps to find out the minor variants of these type of anomalies. And nowadays, unlike most of our patients would like to have a conservative management, and conservative surgical management is preferred. So thank you all for the patient attention. And once again, I thank the team for giving me this opportunity.
Thank you, sir.
Thank you.
Yeah, Dr. Niranjan, please go ahead.
No, please go ahead. You are the chairperson. I'll speak last. Thank you.
Okay.
Thank you, Paul, sir. Amazing lecture. And as usual, it was very fascinating to see the wonderful surgeries. And every time you come up with some new sleeve up your magic trick up your sleeve. So it's really amazing to listen to your lectures again and again. Thank you very much for giving those wonderful videos also. And it's really an inspiration for all of us to enhance our surgical skills also. Thank you so much for that.
Yes,
and thank you.
Welcome.
Yes.
Welcome.
Thank you, Dr. Komal and Dr. Niranjan, for giving this opportunity to us. And best of luck for your elections also, madam.
Thank you so much.
Sir,
Thank
it was
you,
a treat, visual treat to watch the videos and hear you speak. Thank you so much. And thank you once again, Komal and Dr. Niranjan, for this opportunity, and all the best to you, Komal, once again.
Thank you.
Can I ask one question to Paul, sir?
Yes.
Sir, good evening. Sir, with your experience, in which cases of cervicovaginal atresia, preoperatively, what are the critical points you will see which will help you in establishing that this patient can have a patent cervix, or this patient, this cervix will go into restenosis? what are the things you will see on MRI or in the histopathology? I mean, whatever, because many times you may not be able to appreciate the cervical tissue even in MRI because it's completely distended. So what are the critical points which will help us?
I don't have a large series to answer your question, but as you said, the restenosis, before I started doing this, I asked many of my colleagues, and most of them had a bad experience of restenosis. The most difficult part is if both vagina and cervix is absent, your work is little more complicated, and you actually try to make definitely most of these cases will have a adenomyotic uterus and enlarged uterus. So it's slightly difficult to make a decision where to exactly make the opening for the neo cervix. But the most dependent portion we normally select, and I think even if you make little more of cervical enlargement, that may be better than underdoing the cervical reconstruction.
Thank you, sir.
Thank you. PG Paul, sir.
Yes,
Yes, sir. Sir, it's an honor and privilege to be associated with you on this subject of our series done by AGOG, Academy of Global Obstetrician and Gynecologist, where you have delivered a superb lecture, sir, on obstructive Mullerian anomalies. Coincidentally, sir, this was my thesis given in 91 when I joined my residency in Sion Hospital by my madam, and Dr. Gautam Alabadia was my assistant professor, sir. And after completion of my MS, I was working with Dr. P.K. Shah, sir, and there he used to tell me that just this weekend I was in Kerala, I was in Kochi, I was with Dr. Rajan, and I have met Dr. PG Paul there, and I have met Hafiz Rahman. So this is about, I'm talking about 27, 28 years ago. So I started hearing your name since then. And of course, now we are in 2023, sir. So many conferences you have done. Very few people know that sir also was a chairperson of FOXI, and he has contributed a lot. He has also written many textbooks, and his training courses are a super duper hit amongst all the postgraduate students who, after completion of their MS, in those days we had MD, sir, and I recollect, sir, they used to have a long waiting list to be a part of the training program. And sir, you have absolutely made a mark in tubal recanalization, where I remember Dr. Yap-Kip Lee was there. He was a pioneer, and he used to come to Bombay. He used to also come to other parts of India. And I recollect, sir, you were the first person to start the tubal recanalization in India. So we can say, sir, that how we had the father of tuboplasty, Dr. Victor Gomel, and the father of myomectomy, Dr. Bonis. So we can also say that, sir, you are the father of tubal recanalization, and really that has motivated, and the stamp has been made by you. And there are so many, members who are now practicing. I can name the current president of IAG, Dr. Pandit Palaskar, and we have learned all of those surgeries. And I called up sir a few days back. So sir said that Niranjan, I'm done with those tubal recanalization and I want to talk something different. And sir, today you have created history for us, because we are all doing open surgeries, we are doing endoscopic surgery. I have also one case, sir, of 14, 15 years old, where we did, the recanalization of the cervix. Yeah, so it is very interesting, sir, that, and the common problem is of the stenosis which occurs and the follow-up which this young girls have. And really, sir, I like your surgery, especially hitching of the Foley's catheter, something very new and Hemi, hysterectomy is being done on the rudimentary horn. And these are very interesting cases, sir. And I'm really happy, sir, that you have come today. Sir has organized recently the IAGE annual conference in Kochi, and we were a part of that. Parendra was there, and of course, all other. I think there were more than 1,200 members who were a part of that endoscopic siesta, sir. Thank you so much. And I see also George Paul coming up in a very big way. My students still are going to use her, and I'm really happy that they are learning from you and they are imbibing those knowledge. And I'm sure the efforts which you are doing is going to help us. And we have now also MCH, sir, gynae oncology. So I'm sure over a period of time, we will have the university recognizing MCH courses on endoscopic surgeries and even tubal anastomosis, uterine anomalies as the time passes by. So thank you, sir, for being there with us today. And I thank the chairpersons, Dr. Vaishali Sawan and Egbert Saldana, Dr. Parendra, and Malvika Sabarwal, and of course Abhishek. We just heard him now to be a part of this wonderful series of task series along with Dr. Puntam Baker and PG Paul, sir. So thank you, sir, for those wonderful insights.
Thank you, Niranjan, for the nice words, and really enjoyed being in this teaching program. Thank you very much.
Thank you. Thank you so much, sir. It was a fabulous talk. I think the video, we really got to learn something new, and that is really, really wonderful. Thank you so much from bottom of my heart. We just move ahead to the next talk. Amrita, over to you.
Thank you so much, sir. We are really very honored and fortunate to learn from your vast experience. I would also like to thank Dr. Vaishali Chavan, Madam, and Dr. Abhishek Chandavarkar, sir, for chairing the session. Can we have the slides for the next session? So the session 3 is now a talk on tuberculosis and its impact on reproductive health. I would like to invite the chairpersons for the same, Dr. Aditi Nadkarni. She is a consultant OBGYN Century Vapi OBGYN Society. She's trained in reproductive medicine from Kiel, Germany, and USG Medicine. Welcome, Dr. Aditi. Dr. Indrani Roy may be able to join us shortly. She sends her apologies. And Dr. Lavanya Kiran, she's a senior consultant and reproductive medicine specialist, robotic surgeon at Cloud9 Hospitals, Bangalore, and a visiting surgeon at Narayan Health Hospitals, secretary of the IASRM 2022 to 24, secretary of KSR 21 to 23, and she's the founder member of the Karnataka chapter of the IFS. Welcome, Dr. Lavanya, and I request you to please introduce our very esteemed speaker for the next talk.
Thank you so much for the invite. We are so much privileged to be a part of this wonderful educative platform. I'm wishing all our dear friends great luck. Without any delay, I'll introduce Dr. Padma Rike Jirke, who doesn't need any introduction because she's such a wonderful teacher. I've known her personally for a long time. I really love her teaching because she's a very academic person. She's done her MRCOG from the UK. She has FICOG. She's done her MBA in healthcare. She's done her PGDMLE. She's a clinical research fellow in ART from the University of Glasgow. She's a scientific director of Shushrut Assisted Conception Clinic and Shreyas Hospital, Kolhapur. She's a founder director of Pristec Research Foundation, currently pursuing MSc Epidemiology in University of Edinburgh. She's the editor-in-chief for Journal of Human Reproductive Science. She's a reviewer for fertility, sterility, human fertility, reproductive biology, and endocrine journals, Executive Vice Chairperson, Maharashtra Chapter, ISA 2020 and 2022. She's the President-elect for Fertility Preservation Society of India, 22 and 24. She's been the chairperson of SIG Reproductive Endocrinology and PCOS Society of India. She's had to her credit many publications of international journals and contributed more than 20 textbook chapters. Most recent publications have been the latent genital tuberculosis adversely affects the ovarian reserve in the human reproduction, and association of AMH and gene polymerization with ovarian response and pregnancy outcomes in the Indian women. And she's got a lot of credits to her in journal publications in human reproduction and Indian health control and Indian infertility women population study from India and Europe in the reproductive biomedicine online. And I think that is why Madam deserves to be talking on genital tuberculosis. Over to Padmarika, Madam.
Lavanya, thank you very much for that very kind introduction. Komal, can I share my slides?
Yes, you can. Yes.
Yeah, thank you very much for inviting me for this wonderful program. I've been enjoying all the great discussions that have taken place over the last couple of hours, and it's been a great learning experience for me. And I also at the outset would like to wish you all the very best for your endeavors to serve FOGSI and all the gynecologists of this wonderful country. And when Lavanya said that, I do have publications in genital tuberculosis, and that is why I should be the right person to be speaking on this. And what I say now, I say with all humility. I think, tuberculosis and Mycobacterium tuberculosis is something which has remained one of the greatest enigmas. It is as enigmatic as it was, so many years ago when it was first identified. And with all the technological advance, with all the therapeutic advance, it still perplexes us and awaits its diagnosis most of the time. And that is why we need to pay very due attention to this issue of genital tuberculosis. Because India is not one of the high burden countries. Now it is the highest burden country for tuberculosis in the world. And genital tuberculosis is one of the most common forms of extrapulmonary tuberculosis. And it is estimated to cause 5 to 20% of female infertility. This is just referring to the classical tubal damage. I mean, this percentage doesn't even look at what happens to the endometrium or the ovaries. However, the Index TB guidelines, which has the overarching power to guide us as clinicians of this country, published in 2016. We all should be very familiar with this national guideline. So it does acknowledge that infertility may be the only symptom of genital tuberculosis. So what I would address over the next 15 to 16 minutes is association of genital tuberculosis and female fertility, and what are the concerns and controversies that still exist with this age-old issue. The evidence so far does show that it's a common cause of infertility, and it's a common cause of failure of treatment, including IVF. And when we diagnose genital tuberculosis, nearly 90% of them tubes are affected, whether they are patent or blocked. Endometrium is affected in approximately 50% of them. And it is generally said that ovaries are affected in 30%. This refers to age-old references, which actually identify visible oophorytis or ovarian abscess. Evaluation should involve assessment of not only just tubal, but also endometrial and ovarian function as well. But this is just a guideline without actually telling us what we should be doing to assess the endometrium or the ovaries. So this is a publication from India itself in 1990 7, which actually looked at the fertility outcomes and IVF outcomes in women with various causes, and showed that those with proven genital tuberculosis have frozen pelvis most of the time, and it does play a role in reducing the success rate in IVF. Further publication, again coming from India, did show that it could be a cause of infertility in as high as 60% of the cases, and it is often underreported because of asymptomatic infection and paucity of investigations. And genital TB could be an associated factor in about 7% of infertile women. And also it did allude to a high percentage of them eventually achieving pregnancy through IVF after having failed all simpler forms of treatment. So then, various publications did follow highlighting why, how tuberculosis continues to be an important factor for female fertility or infertility. And laparoscopy then became the most important tool to diagnose tuberculosis. And it was then identified that extensive structural damage to pelvic organs is probably what causes infertility. And also around the same time, it was recognized that undiagnosed tuberculosis can lead to transplacental transmission and neonatal tuberculosis as well. Further evidence specifically, looking at IVF did show that with structural damage to pelvic organs, need for IVF increases, and latent infection may need to be considered in unexplained recurrent implantation failures. And during IVF, it was also noted, not just in India, but also across the globe, it was noted that these women do require high doses of gonadotropins, more than what is normally necessary, suboptimal ovarian response, poor oocyte and embryo quality, and poor implantation rate. And then started, with the advent of hysteroscopy, some of the work to identify how the endometrium is damaged, and it was recognized that uterine adhesions do play a role in causing female infertility. Still, none of the guidelines talk about hysteroscopy as a tool for diagnosing tuberculosis till date. So one more study did say that if you notice thin endometrium and there are endometrial uterine adhesions, treating them successfully may improve the endometrial thickness, and it could be structural damage and also vascular damage, which makes it unsuitable for implantation, and rectifying the problem may improve the outcomes. This 2016 Index TB guidelines published by the Government of India actually governs whatever we do for tuberculosis, especially as far as diagnosing and medical therapy is concerned, and we all should be familiar with this. It points to 3 different ways of diagnosing it. One is presumptive diagnosis, that is a patient with symptoms and signs of extrapulmonary tuberculosis who needs to be investigated. Then bacteriologically confirmed case, a patient who has a microbiological diagnosis of extrapulmonary tuberculosis based on positive microscopy culture or validated PCR-based test. Then clinically diagnosed case is a patient with negative microbiological tests for tuberculosis, that is on microscopy culture and validated PCR-based test, but with strong clinical suspicion and other evidence of extrapulmonary tuberculosis, such as compatible imaging findings, histological findings, ancillary diagnostic tests, or response to anti-tuberculosis treatment. So these are the 3 ways of diagnosing we should be familiar with. And I think all of us will agree that presumptive diagnosis and treatment is very worrying, and we should resort to this only extremely under extremely rare scenarios. And it's a good clinical practice to document as to on what basis, whether it's a bacteriologically confirmed case, clinically diagnosed case, or presumptive diagnosis based on which we are treating somebody as genital tuberculosis. So the recommendation also, the guidelines also concluded that the diagnosis should be made based on any of the laparoscopic appearance, or any gynecological specimen positive for AFBs on microscopy or positive for tuberculosis MTB on culture. So the question arises as to whether, just doing a presumptive diagnosis or clinically diagnosing it without any supportive microbial diagnosis, whether it is too simplistic or whether we should use it routinely. The overriding concern is that it's a potentially reversible cause of female infertility. And so we may actually be tempted to overdo, whether it is in the form of diagnosis or in the treatment. So it is very important that we need to be aware of what tools we have for making the diagnosis, what are the national guidelines, and we should practice within the confines of these guidelines. So when we think of clinical diagnosis, first and foremost is the high index of suspicion, where prolonged infertility, scanty menstrual loss, or those with previous ectopic pregnancies, recurrent pregnancy loss, or there is family history of tuberculosis with somebody receiving treatment within the family. All this should lead to a high index of suspicion. And this can be supported by ultrasonography, hysterosalpingography, and in more recent years, MRI also has been used for diagnosis, and then direct visual assessment. That is classically through laparoscopy. I have added hysteroscopy because I think one day or the other, the next guidelines will have to look at the role of hysteroscopy as well. So then we all know the most important sign in the ultrasound is to look at the endometrium. If it looks thin, inappropriately thin to the phase of the menstrual cycle, or if we see some fluid collection or a band of adhesion in an infertile woman, we should be considering tuberculosis as a possible diagnosis. Or when we see a large retort-shaped hydrosalpinx in one of the both adnexa, that is another indicator. HSG can show the same hydrosalpinx or a blocked tube at various levels from corner to any length of the fallopian tube, or very grossly damaged stenosed uterine cavity. So these are all very strongly suggestive of tuberculosis with radiological investigations. And we're all very familiar with what we all can identify laparoscopically, including the Fitzhugh syndrome, Fitzhugh-Curtis syndrome. Hysteroscopy is something which is not classically addressed in the old textbooks or old publications or the guideline, which is as recent as 2016. But we do know that uterine presentation could be the only presentation indicating presence of tuberculosis, various levels of adhesions from one or two thin flimsy adhesions to totally destroyed uterine cavity, or it could be just a thin, pale, bald endometrium. So the presentation again can vary. But what are the dilemmas we have as far as diagnosis is concerned? As far as I'm concerned, I think treating tuberculosis, whether structural damage or medical therapy, I don't think there is any issue. There is huge level of expertise available within this country as far as surgically treating any pelvic damage is concerned. If a pelvis can be restored to its normalcy, it would be done surgically. There is absolutely no doubt about it. And we also know how we should treat medically a diagnosed tuberculosis. But the dilemma, the most important dilemma that exists is if we just clinically look at a structurally damaged pelvis, or we do a radiological diagnosis of damaged pelvis, either the uterine cavity or the tubes, should that in itself be sufficient to label it as tuberculosis and subject them to 6 months course of anti-tuberculosis drugs, or how best we can obtain a bacteriological diagnosis? Because we have to remember that a percentage of these women will remain infertile at the end of all efforts. And also there are certain documented side effects, although not very rare, although not very common, with the medical therapy for tuberculosis. So there are medico-legal issues associated with this. So how do we try and establish a bacteriological diagnosis? The age-old way was to look at the Mantoux test, and now we know that the WHO recommends. WHO actually sort of governs the tuberculosis management, diagnosis and management throughout the world, and their recommendations are. Sorry, there is some disturbance here. Hello, Lavanya. Yeah. So Mantoux is something which is not recommended for high burden countries because it can be very, very non-specific. And using serum IgG and IgM, which was very common about 15 to 20 years ago, but even now we see that occasionally that is non-specific and should not be done. IGRA again is not valid for genital tuberculosis, and these have to be acknowledged and respected. Now, what about bacteriological diagnosis? We know that originally it has been used for diagnosing pulmonary tuberculosis, and on a smear to diagnose tuberculosis, it requires about 10,000 organisms per ml, and this is something we will never get in genital tuberculosis. What about culture? It has high sensitivity but low specificity. So the traditional culture used to take 6 weeks, and now the BACTEC liquid culture reduces the time by 50% or so. Still, it has a detection. It needs at least about 100 organisms per ml to make the diagnosis. I'll come back to the culture a little later. Coming back to the index TB guidelines, it acknowledges that infertility is a serious outcome of genital tuberculosis, and it says that about 11% those with genital tuberculosis may present without any other symptom other than infertility, and it acknowledges the limitations of conventional tests, and PCR tests, based tests are increasingly being used, but the guideline group decided that the recommendation was not possible at this juncture regarding the use of PCR-based tests for female genital tuberculosis, and noted that high quality diagnostic test accuracy studies are needed to address this question. So then came one of these, around this time came this publication from again India, looking at using only DNA PCR for diagnosing. This is from North India, diagnosing genital tuberculosis, and after treating, they reported very similar pregnancy rate to a group which did not have genital tuberculosis. But what are the challenges of using even a molecular based technology for diagnosis? Genital tuberculosis is a paucibacillary condition, and obviously 2 of the 3 organs that might be affected, that is ovaries and fallopian tubes, we cannot obtain biopsies because it is considered unethical. An endometrial biopsy can miss an area of infection. Because the endometrium is shed very regularly, it is very unlikely that we notice any frank ulcerations and granuloma formation. So it most of the time goes unnoticed, and there is this phenomenon of latent genital tuberculosis. Latent tuberculosis anywhere in the body is now very well recognized that is not a inert condition. It does, and genital tuberculosis being latent is very common because the vascularity and the hormonal environment is very conducive for the mycobacterium to stay there and grow there. It does, when there is latent tuberculosis, it's not an inert condition because the tissue where the bacteria is, there is a local immune reaction mounted. So there is a low-grade inflammatory or immune reaction going on, which can still lead to, even though it prevents the infection becoming obvious and a clinical infection and causing structural damage, it can still be causing damage in a silent manner. So, and we know that latent tuberculosis contributes to a large reservoir of tuberculosis globally, and 10% lifetime risk of active tuberculosis is there, and conversion is higher in those with altered immunity. And we do know that many of the associated conditions with infertility, we conventionally say that the pelvic immunity is altered. So tuberculosis can be a silent companion under these circumstances. So continued interaction between the body and the Mycobacterium tuberculosis can be causing microscopic damage to the tissue, which goes very unnoticed. And the most important thing about those who argue about culture being the gold standard for diagnosis of genital tuberculosis is that latent genital tuberculosis is not culturable. The way the capsular changes happen in the bacteria, that is one of the characteristics of the infection being latent. So a latent tuberculosis anywhere in the body is not culturable. And now if we divert our attention towards what happens to ovaries in tuberculosis, for a long time, there was no published work on tuberculosis and ovaries. Until date, we have the publication containing the largest number of people studied. So this was in otherwise unexplained women with unexplained infertility, more than 800 women. And we had certain criteria in that at least they should have had 2 years of infertility, proven patent tubes, and no other obvious cause for infertility. So in this subset of women, we did actually identify that both the robust ovarian reserve markers, that is AMH and AFC, were significantly lower in those who were diagnosed to have latent tuberculosis. That is, in that they had infertility and the DNA PCR was positive. So with only these 2 criteria, when their ovarian reserve was evaluated, there was a significant reduction in the ovarian reserve. But what we also found was, after successfully treating with standard ATT for 6 months, there was a significant increase in the pregnancies that were achieved in those who were treated for tuberculosis, both through ovulation induction and also in IVF. A fair number of them, in fact, conceived with simple modalities of treatment. And if we look here, this is despite having a low ovarian reserve compared to the other group. These women did have low ovarian reserve. They did produce less number of oocyte, but still they had a better pregnancy rate following treatment. So there appears to be something that is happening in the ovaries as well, even in women where no structural damage to the ovaries are identified. Now coming to this issues associated with molecular diagnosis of female genital tuberculosis, the most widely used is DNA PCR. It has very high sensitivity and specificity, and concerns of high false positivity are exaggerated because they are done in very dedicated setups, and there is no issue of contamination and overdiagnosis, which was being quoted as a common reason for avoiding these tests about 15 years ago. And now Gene Expert, or TrueNAT, which identifies a particular gene in the Mycobacterium tuberculosis, is considered as one of the important modalities for diagnosing. So we also have to consider at this juncture whether these commercially available units are the best ones for our population, or we need to look at homebrew tests which are very relevant to our own population. We also haven't evaluated 2 fairly low-cost alternatives, that is immunohistochemistry and LAMP, which probably in future will take center stand. The reason Expert MTB-RIF or TrueNAT is being promoted as a good diagnostic modality for genital tuberculosis is because it comes under the ambit of WHO consolidated guidelines. However, it is very important to remember that we need to understand the limitations, because they are commercial assays and they come with everything to identify one particular gene of or one particular area of the bacterial genome of the Mycobacterium tuberculosis. And in our country, more than one genotype exists, and depending on the geographic area where we are doing the testing, the percentage of these bacteria with different genomes are defined actually. So we need to be aware of that to choose the right molecular diagnosis. So using these commercially available kits, which will identify only a particular set of genes, actually is not the right way to move forward, because especially in southern half of the country, nearly 30 to 35% of the women who have genital tuberculosis will have the bacteria which doesn't have the gene which we are trying to look through with GeneXpert or TrueNat. So that is something we need to be very cognizant of. So how do we go through this confusing scenario of genital tuberculosis? The reason it is very important to make every effort to do the diagnosis appropriately is that I go back to the study we have published, and since then there have been 2 small studies replicating the results we have shown, in that it is one of the only known reversible condition where the ovarian reserve is reduced. We all know as gynecologists that when the ovarian reserve is reduced, many of them will not conceive with their own eggs, and they may require third-party reproduction in the form of egg donation. And it is a emotionally, mentally, financially, legally difficult area, and we owe it to our patients that we do everything possible to help them achieve their dream of parenthood through their own gametes. And this is a very interesting and potentially very rewarding area if we can identify the condition before irreversible damage happens to the ovaries, and if we can reverse the damage to some extent at least, then we actually give them the hope of conceiving with their own oocytes. So we need to have a workable algorithm. In the absence of any of the national guidelines, I have made an attempt to sort of create this algorithm to say in who should be investigated. It is women with infertility, at least having had some duration of infertility in the absence of obvious male factor infertility, where they have received some amount of supervised standard treatment for infertility, and evaluate them early if there are no obvious problems found clinically, radiologically, and if necessary, endoscopically, but add hormonal evaluation to look at the ovarian reserve, including both AFC and AMH, to look for abnormal reduction in the ovarian reserve, and then laparoscopy. And we need to define the role of hysteroscopy as well. It is something totally neglected so far. And what do we do with one simple endometrial biopsy? Do we do BACTEC culture? Do we do DNA PCR? These are the questions which need to be decided. Or do we subject it for simple traditional histopathology? In all these years, we have diagnosed histopathologically genital tuberculosis so far in 4 patients. So we need to be aware of what our patient population is like and how much we are helping by subjecting them to repeated investigations which are not yielding the result. And we need to keep our eyes open for newer tests, even under research setting. Whole genome sequencing of Mycobacterium tuberculosis has been successfully achieved. So these are something very interesting, at least from the research point of view. And then we need to, once diagnosed, we need to obviously treat it very appropriately, and then offer the infertility treatment depending on what is the condition of the pelvis and what is the overall picture of infertility. So if diagnosed and treated before visible structural damage happens, as we have shown, nearly 50% of them conceive without IVF. And in those needing IVF, pregnancy rates are good even in those with low ovarian reserve. So I think considering the immense benefits, it's important that we have a workable algorithm and create a composite reference standard, which is very normal for many types of extrapulmonary tuberculosis, but is lacking for genital tuberculosis. So the treatment, we are all very aware, 2 months of intensive phase followed by, that is 4 drugs, followed by 3 drugs for the next 4 months in the continuation phase. Once diagnosed, because it is a reportable condition, it is mandatory that we report, and it is amazing how the JEET program, the tuberculosis TB department, within the geographical confines, how prompt they are, how well the whole the counseling of the patients and registering them and initiating the treatment and regular follow-up is provided by these government officers and their team. And of course, once the intensive phase is over, it is absolutely okay to encourage them to conceive and go ahead with whatever forms of treatment are necessary. But it is known that if tuberculosis is not treated, and women do conceive, and if they do not miscarry, then there is an increased risk of PIH and small for gestational age babies. And we need to be prepared for multidisciplinary management to take care of pregnant women with tuberculosis. So to summarize, female genital tuberculosis, while not communicable, has devastating consequences, and infertility is the most widely recognized and serious effect of these elusive conditions. Of course, they may present with pure menstrual disorders and dysmenorrhea as well. Clinical diagnosis is by laparoscopy and supported by ultrasound and HSG. Role of hysteroscopy is underrated at present. Bacteriological diagnosis is ideal but challenging, and molecular diagnosis offers an effective alternative. The most suitable tests need to be identified based on geographical area where we come from and what kind of genotype is largely present in that area. GTB related challenges in diagnosis are yet to be addressed either by WHO or our own index TB guidelines. And we should offer them all 6-month standard ATT. And the major problems we face as far as women's reproductive health is concerned and genital tuberculosis is delayed diagnosis, no uniform policy of treatment. I'm very sure all of us come across people who have received 3 drugs for 3 to 4 months and then they have stopped treatment or they've not been supervised appropriately. So recommendations for diagnosis and treatment of latent female genital tuberculosis is another area where we need to consolidate our experiences, and we need to standardize the conditions under which molecular tests should be performed, and the list of reference laboratories are also necessary. And early diagnosis does save female fertility, and nearly 50% of them conceive with simple treatment modalities. And latent genital tuberculosis with infertility is not without harm. Thank you.
And now I think the whole platform knows why I called you a wonderful academician, because I think you've really done justice. Because I remember last year, Isar, I had this genital tuberculosis as my talk, and the craziness I went to even get something was really so difficult, and you've really made it so simple. As wonderful points of, though it being a non-communicable disease, it's causing almost 11% of infertility, and I think that's really high. And then how laparoscopic has been more important compared to hysteroscopy, because hysteroscopy has not been on the line so far. And how you mentioned of clinical history becomes very important than any differential diagnosis or any modality that needs to be used, including telling us that how AFB specimens are not much relevant, using different methods of diagnosis from DNA molecular testing has become more appropriate, and MON2 is no more to be done. And then how, you reassured us that while treatment is very good and it's something reversible treatment and it's a disease where we can definitely help, and you've cleared all the dilemmas of how to treat them, when to treat them, and reporting, and the JET program and reporting, I think, is to be mentioned always, and follow-up is very important, and assuring us once she conceives that we don't have to be worried where pregnancy is going to go beautifully well, though she has a little risk for hypertension. Beautifully put across, ma'am, and I think you've made the gist like really well and in very simple terms. Thank you so much. And I would like to wish my dear friend Komal a great luck. And I would only say she's such a great leader, not because she achieves a lot of things. The great leadership is in taking a lot of other people along with them. And that's what I think is greatness about Komal. And she's such a simple person. Wishing you a great luck, Komal.
Thank you. Thank you so much, Dr. Lavanya. And it was really an eye-opener talk by Dr. Padma. I think she has really spoken so much in detail. You know, we try to struggle managing these patients with tuberculosis, and we really hope for miracles. But we know like how we have to actually go about, and what are the success rates, and how do we go about counseling them. That is really very important, because tuberculosis is there. There are the childhood tuberculosis patients who come now, and the history which is also not very positively given by them. So with all that, we do struggle, and with infertility, it becomes a big challenge. It was lovely talk, Dr. Padmarekha, and you were the best person for the talk. And thank you, Amrita. Thank you so much.
Thank you. Thank you, Dr. Padmarekha. Really, it was such in-depth insight into this topic. And we are very lucky to have heard you on this platform. And I would also like to thank Dr. Lavanya Kiran and Dr. Aditi Nadkarni for chairing this session so beautifully. With this, I think, we will end the session for today. And I would like to hand over the mic to Dr. Komal Chauhan for her concluding remarks, and also my best wishes with you, ma'am, always. And we are looking forward to your tenure.
Thank you. Thank you so much, dear Amrita. And at the outset, I would like to thank our lovely coordinators, Dr. Amrita, Dr. Hafizur. They are really great people, I think, really upcoming, and they are the future. So I'm so happy that they are there with me and associated with me. Our eminent speakers, Dr. Puntambekar, Dr. P.G. Paul sir, and Dr. Padmarekha Jirge. I think each talk was as wonderful. You know, I think I've totally glued and mesmerized to my seat, hearing each one speak. Our chief guest, Dr. Alka Kriplani, and guest of honor, Dr. Gokul Das, for gracing the inauguration. Our lovely chairpersons, I think Lavanya is there till the end. Dr. Egbert also was here. And Dr. Farendra, Dr. Malvika Sabharwal, Dr. Vaishali Chavan, Dr. Abhishek Chandavarkar, and Dr. Aditi Nadkarni, all were there. And they have made the program very interactive and so successful. And we have a great viewership today. So many people have logged in, and I'm receiving so many messages, positive messages with comments for all the talks, I think. And the recording also will be visualized, and it will really be helpful to so many practicing gynecologists all over India and worldwide. With that note, I thank you all. Thank you, Shield Connect, for connecting us. And we'll see you again in the next episode 2. Thank you. Thank you so much.